Arthrology. The elbow includes three joints inside the same capsule: the ulno-humeral joint, the radial-humeral joint, and the proximal radial-ulnar joint. The ulno-humeral joint. The ulno-humeral joint is a trochlear-type articulation linking the greater sigmoid notch of the ulna to the humeral trochlea. With elbow flexion, the coronoid process, which is located anteriorly to the sagittal crest, enters the coronoid fossa. With elbow extension, the beak of the olecranon enters the olecranon fossa, limiting elbow extension. The radial-humeral joint. The two articular surfaces of this joint are the hemispherical humeral capitellum and the articular fossa of the radial head. This joint is anatomically an anarthrosis, also known as a ball and socket joint. It is functionally linked to ulnar motion through ligamentous connections. Radiocapitellar articulation restrains valgus stress from 0 to 30 degrees of flexion. The proximal radial-ulnar joint. The articular circumference of the capitellum adapts and rotates on the concavity of the lesser sigmoid notch of the ulna. It forms a trochoid joint that cannot be dissociated from the distal radial-ulnar joint. These rotational movements, known as pronation and supination, can be performed throughout the entire arc of elbow flexion and extension. The proximal radial-ulnar joint is stabilized by two ligaments. The annular ligament of the radius attaches to the anterior and posterior aspects of the lesser sigmoid notch around the neck and head of the articular surface of the radius. The internal face of the annular ligament is covered by a small layer of hyaline cartilage, which facilitates the rotation of the radius inside this fibrous ring. On the other hand, the quadrate ligament, also known as Deneuse's ligament, is a thin fibrous band that connects to the inferior edge of the lesser sigmoid notch with the radial neck, with expansions extending to the menisci located on both sides of the lesser sigmoid notch of the ulna. When the radius rotates in pronation and supination, this ligament becomes taut, limiting these movements. The joint capsule and ligaments. The fibrous articular capsule covers the elbow joint. Anteriorly, the capsule originates above the radial and coronoid fossae and attaches to the annular ligament, the anterior aspect of the coronoid process, and the two ulnar notches. This insertion is approximately 6 millimeters distal to the tip of the coronoid. The coronoid process is intra-articular and is visualized during elbow arthroscopy. The epicondyles are extracapsular. The capsule surrounds the joint, attaching the posterior aspect above the olecranon fossa. The capsule allows maximal distension at 70 to 80 degrees of flexion, which is why patients with an effusion hold their arms in this position. The medial side of the elbow is reinforced by the ulnar collateral ligament, which includes 3 fascicles or bundles or bands. The anterior fascicle extends from the antero-inferior surface of the medial epicondyle to the medial coronoid process and attaches 18 millimeters distal to the coronoid tip at the sublime tubercle. It is the most important restraint to valgus stress. It is always taut and typically ruptures off the coronoid process. The anterior band is taut from 60 to 120 degrees of flexion. The transverse bundle inserts at the medial olecranon and the medial inferior coronoid. It is responsible for stabilizing the greater sigmoid notch. There are 4 names for this ligament in the literature: transverse ligament, transverse fascicle, oblique medial ligament, and Cooper's ligament. The posterior fascicle originates on the posterior inferior aspect of the medial epicondyle and attaches on the medial aspect of the olecranon. It is taut and resists valgus stress when the elbow is at 90 degrees of flexion. The lateral capsule is reinforced by the lateral collateral ligament. It has three components: the lateral ulnar collateral ligament, the lateral collateral ligament, and the annular ligament. There is also the accessory collateral ligament. The lateral collateral ligament inserts at the lateral epicondyle and the anterior annular ligament. It provides varus restraint and stabilizes the annular ligament. The lateral ulnar collateral ligament inserts at the lateral epicondyle and the supinator crest of the ulna. It serves as a buttress to radial head subluxation. Injury to this ligament results in posterolateral rotary instability. The annular ligament attaches at the anterior and posterior portions of the sigmoid notch. It allows radial head rotations and is either stretched or torn during injuries involving radial head subluxation or dislocation. Other ligaments outside the MCL, LCL, and capsule include the quadrate ligament. It attaches at the anterolateral ulna and the anterior radial neck under the annular ligament. It is tight in supination and stabilizes the proximal radial ulnar joint. The oblique cord. The oblique cord attaches from the proximal lateral ulna to the radial neck and stabilizes the joint during pronation supination. The arcade of Struthers. According to the standard anatomic definition, the arcade of Struthers is a fibrous band that usually extends from the medial head of the triceps to the medial intermuscular septum. It's located approximately 8 to 10 centimeters from the medial epicondyle. Osborne's ligament can be classified as the fibrous band bridging the heads of the flexor carpi ulnaris as originally described by Osborne. It's also described as the ligamentous tissue connecting the olecranon and the medial epicondyle.